Good morning. Hope all of you are safe at your homes. We thought by 1st of July we will have our college open, hospital open, but unfortunately Corona was thinking otherwise. So we need to continue our online classes for some more time to come. So I request all of you to get up at least from your beds, and as we are discussing something about spine, keep your posture erect, correct posture, sit properly at least during the duration of this class, and listen to this class. And as usual, after the class is over, you need to go back to your textbooks and read it once so that it gets imprinted in your hard disk so that you can retrieve the information as and when you need it. Regarding this pandemic Corona, the situation is really grim, and all of us should try to be safe, not only ourselves, our family, our friends, neighbors, relatives. And being a medical student, you are an ambassador of health. So you need to impart this health education to whoever comes across you. They may be our maids working in our house, our drivers, our cooks, anyone, our family, friends, relatives. So you need to take up, and no measure is small in this. You need to do hand washing on a regular basis and use other safety measures like hand sanitizers using often, and social distancing. And don't go out for shopping or just like that because you are homebound. I think it's nearly around 100 days, maybe a few days short of a century. So it's very difficult. I know you guys, you want to be out, and anyway, college is not there. You are very happy, but don't go out during this time, because you should imagine that every other guy whom you come across is positive, and you should be aware that you may catch that infection from him. And the situation out there is really very serious. It's very difficult for anyone to get a bed in any of the hospitals outside unless you are very influential or a politician. So I hope it should not come to that for any one of us. For that, we need to make some efforts from our side. So let us start the class. This is about spine and spinal injuries. All of you know that spine is made up of several vertebrae, and the vertebrae are named according to the region they are present in. Cervical, dorsal or thoracic, then lumbar and sacral. So the spine is a very stable, it should be a stable structure to have the body normally on top of it. So the stability is very important and paramount to the spine, and along with stability it should be flexible. A stable spine without flexibility is of no use. It's like a wall. You may not be able to bend down and do any work. So at the same time, it should be stable. A flexible spine without stability is also useless. So you need to have stability as well as flexibility, and because of the various joints which are present in the spine, these two are maintained. And these vertebrae, individual vertebrae, they are held with each other by means of very strong ligaments. The spinal ligaments and spinal muscles, the back muscles, are one of the strongest ligaments and the strong muscles in the body. And as all of you know that the spine can be divided into cervical spine, thoracic or dorsal spine, lumbar spine and sacral spine. And out of these four areas, it's more mobile. It's mobile in cervical and lumbar. You can bend or nod and rotate your head, and you can do all these movements in the lumbar spine. But thoracic spine, because it contains the important organs, it has attachment of the ribs. It's not mobile. It's immobile. So thoracic spine and sacral, because they enclose very important organs and give protection, they are not mobile. The other parts of the spine are mobile. Coming to the other cut section of the spine along with attachments, you need to know these are the vertebral bodies. This is a vertebra and this is another vertebra, and in between these two you have what is known as a disc. A disc is enclosed in a fibrous sheath. So this is called annulus fibrosus, and the inside material is called nucleus pulposus. So this is the vertebral body, and this is the anterior side, and this is the posterior side, where you get all the posterior elements. So anteriorly, you have a anterior longitudinal ligament. This is the anterior longitudinal ligament which gives strength anteriorly to the spine. And these vertebra, the ends are called end plates. This is an end plate. This is an inferior end plate of a upper vertebra, and this is the superior end plate of the inferior vertebra. And posteriorly you have posterior longitudinal ligament. So this is the posterior longitudinal ligament, and this is the anterior longitudinal ligament. They are in touch with the body of the vertebra, anteriorly and posteriorly. There may not be any confusion. If you know that there are two longitudinal ligaments, one anterior and one posterior, in touch with the body of the vertebrae. So other important ligaments are, so this blue structure which is there is called ligamentum flavum. This lies posterior to the body of the vertebra, ligamentum flavum. This is attached to the pedicule. Lamina of the vertebra, ligamentum flavum, and these are the spinous processes. So this is the spinous process of this vertebra, and this is the spinous process of this vertebra. So these two spinous processes are connected by means of interspinous ligament. So this green one which is depicted here is interspinous ligament, and the most posterior one is this supraspinous ligaments. There may not be any confusion here, because the supraspinous ligament lies above the spine of the vertebra. So supraspinous ligament, and interspinal ligament lies in between the two spinous processes. So this is ligamentum flavum, and this is posterior longitudinal ligament, this is anterior longitudinal ligament. So these are some of the ligaments which give strength to the spine and stability. So normally pictorial depiction, whenever you are standing erect, then this is the spine, normal spine, and this is in flexion and this is in extension. This is in flexion, forward bending, flexion, and this is extension of the spine. And in these two movements also, it is normal. So you can see all the structures are in place. Only movement is extension here and flexion here. So normal spine, extension and flexion. Coming to the anatomy of a vertebra, you should know some terms to understand what is happening. This is a superior view. You are viewing the vertebra from the top. Once you do that, so on the top you can see a intervertebral disc. So this is the disc on top in between two vertebrae, and this is the body of the vertebrae. The main parts, it's very easy for you to remember if you follow what I am trying to tell you. This is the body. All of you know that there is a body here, and transversely the structure which lies here is a transverse process. You will have two transverse processes, one on the right side, one on the left side, and the structure which is there in the posteriorly like a spine, this is called a spinous process. Till now we have seen a body, transverse process and spinous process. Coming to the structure which connects body with the transverse process, this is called a pedicle. A pedicle is one which connects transverse process to the body, pedicle, and the structure which connects the transverse process to the spinous process is called a lamina. So there should not be any confusion. This is the body and this is the pedicle. These are the transverse processes on either side. This is the lamina and this is the spinous process. And they enclose the posterior elements, they enclose the vertebral foramen, which is a very important through this the spinal cord passes. So these are some of these structures. Along with that, you will have what is known as a superior articular process. A superior articular process, and you will have the attachment with the other articular process of the other vertebra. So they are called zygapophyseal joints. So this is in brief about the anatomy of a vertebra. Coming to the spine injuries, or we consider spine as having three columns. If you know this theory, then it will be easy for you to depict the spine as a whole, and you can picture the spine, how it is formed, what are its functions, and whenever there is an injury, how serious they will be and how to manage these things. So Dennis proposed this theory and he divided this spine into three columns. This is the same picture like before, which depicts the body of the vertebra here, and these are the posterior elements. Posterior elements contain the spinous processes, the transverse process, the lamina. All these things are coming into the posterior elements. Here he proposed that it can be divided into three columns. Anterior column, here you can see anterior column, the red arrow depicts anterior column. The middle one is the middle column and the posterior column. Anterior, middle and posterior columns. So what does this anterior column consist of? Anterior half of the vertebral body. So if this is a vertebra, the half of it, the anterior half along with the anterior longitudinal ligament, and you have the disc in between two vertebral bodies. So this is a inferior vertebra, this is a superior vertebra. In between this gray area is a disc. So this anterior column has a anterior half of the disc involved in this. So anterior column consists of anterior half of the vertebral body, anterior longitudinal, coming from anterior side, anterior longitudinal ligament, anterior half of the vertebral body and anterior half of disc. So this constitutes anterior column. Coming to the middle column, so this arrow depicts the extent of the middle column. Here you have posterior part of the body, posterior half. This anterior half, this is the posterior half. So this posterior half of the body and posterior part of the disc and posterior longitudinal ligament. So there should not be any confusion which constitutes anterior column and which is the middle column. So this is the middle column. Middle column consists of posterior part of the body, posterior part of the disc and posterior longitudinal ligament, and all the other things which are remaining, they go into posterior column. What are they? So the posterior column, this red arrow indicates the extent. Here the posterior vertebral arch. The other structures apart from body, what all you have learned till now, the transverse process, the pedicle, the spinous process, lamina, all these things, and constitute the posterior column. So it consists of posterior vertebral arch, including transverse process, spinous process, and the ligaments between them. The supraspinous ligaments, the interspinous ligaments, all these things, they constitute the posterior column. So there should not be any doubt between these columns. Coming to the stability, it should be more stable. Whatever we do, unless the spine is stable, we will not be able to achieve any work done. So as long as the columns are intact, spine will be stable. If there is any discrepancy in the columns, then the instability comes in. One column injury, mainly the anterior column, if it is injured, only anterior column. Anterior column is anterior longitudinal ligament, anterior part of the vertebral body, and anterior part of the disc. If there is injury to this column only, then it is stable. The spine is not unstable. But if the other columns are involved, if all the three columns are involved, or if only the posterior column is involved, it becomes unstable. Okay, so you should remember this. This is a rule of thumb. Whenever a spinal injury comes, you need to decide which column is involved in that. If it is only anterior column, okay, fine, there may not be any neurological symptoms and spine is stable, so there is the room for conservative management. But if more than one column is involved, and if the posterior column alone is involved, then definitely there will be some instability and there may be some neurological element also in that. And this is nature's way of keeping it stable. Like our spine, these are stable. This is during my tours, somewhere I got this photograph done. Coming to cervical spine. Cervical spine, because most of us have brains, and the brain extends down as a spinal cord. So the cervical spine consists of 7 vertebra, C1, 2, 3, 4, 5, 6, and the cord in between, in the neuroforamen. Here, the common injury is hyperflexion. Hyperflexion mechanism leads to injury of the cervical spine, and which is the commonest mode of injury. And when a head is injured by a fall of weight from a top, then suddenly it will go into, most often it will go into flexion. And whenever you land on your head during a dive or a fall, then it may lead to a hyperflexion injury. And whenever that happens, it may associated with fractures as well as dislocations. So this is a basic structure of the cervical spine. So all of you can see these are the vertebral bodies, and in between the vertebral bodies you have the disc. Okay, and this is the spinal cord, and the spinal canal, this blue and this yellow one is the spinal cord, and these are the posterior elements, and these are the spinous processes, and on the top of the spinous process, this is the supraspinous ligament, and in between interspinous ligament, like we have seen. This is a typical view of C4 and C7. The peculiarity here is C1 and C2, they are atypical vertebrae. They have a special function. So they are unlike other cervical vertebra. C1 is known as atlas and C2 is known as axis. Coming to fracture dislocation of the cervical spine. So here you can see the vertebra here is not properly aligned like these two vertebrae. This has come far forwards when compared with the alignment. So there should be a fracture somewhere to have this type of picture. Once this type of injury happens, like here you see, so this is the cervical spine, and here this vertebra is far forwards than this. Okay, all of you can clearly see the whole cervical spine moved forwards over this. To have this thing to happen, there should be an injury of the bilateral facetal joints. The superior and inferior articular joints, which we have already seen of the vertebrae, they are injured. Otherwise, this will not happen. What happens in these type of injuries? See, there is a fracture and dislocation. There is a dislocation here. All of you can see that the vertebra here has moved far forwards over the vertebra lying down beneath it. So here it's a pictorial depiction. Here this vertebra has come far forwards over this. Then the disc in between these two, this is pressing on the spinal cord. You can see the buckling, or it pushes it from one side. Because of this pressure, there may be some neurological symptoms. It may be a sensory, or it could be a motor deficit. So this is the mechanism by which patients may have a neurological complications after injury to the spine. This is a basic mechanism. And after some time, if the injury is severe, or after some time, this disc which is bulging, which is herniating here, may become sequestrated. That means that permanently lies in the spinal canal. See, this is only a guest here. It is just there and pushing it. But this occupies the spinal canal. Once this is done, then definitely a sequestrated disc is more likely to be symptomatic than a herniated disc. If you take an MRI of say around 40 years, you will find multiple disc bulges. So disc may just bulge and may cause a minimal pressure here. That may not lead to any symptoms, or sometimes it may be symptomatic. But a sequestrated disc in most occasions will lead to symptoms, definitely. So this has to be removed. So this sequestrated symptomatic disc has to be removed, and this dislocation has to be corrected. How they do it, we will see later on. So this is the basic mechanism of injury in spinal injuries. Why these neurological signs and symptoms and neurological deficit occurs. Sometimes it may be a total paraplegia, or quadriplegia, or quadriparesis, or monoparesis. So there are several terms and several combinations also which can occur because of this injury. Coming to some names which are associated with these cervical spine injuries. So Jefferson's fracture, this goes, it's an eponymous fracture. It goes on the name of Dr. Jefferson. He was a famous neurologist. He coined this, named it after him. And here what happens is, it's a burst fracture of the atlas. This is the normal architecture of atlas, and there is a burst fracture here, you can see. And this is C2, it has a process, prominent odontoid process. You can't miss it. So whenever a vertebra is seen with this process, it's C2. To see this, usually we need to know or do what is known as open mouth view of the X-ray. See, all of you can see the teeth here. That means patient was made to open his mouth, and X-ray was taken when his mouth was open. Then you can clearly see this odontoid. So this is C2, and this is a C1, and there is a burst fracture here. So it ranges from a minimal to say fatal injury, because the most important structures in the brain stem and beginning of the spinal cord may be injured along with the fracture, and patient may be dead initially in the first go itself, or it may be a minimal injury and it may not lead to any fatal consequences. So depending upon the severity of the injury, it can be treated by means of rigid collar immobilization, or sometimes you may need to resort to fixing. So this is a scanning image wherein you can see this is the C1 vertebra, and here you can see clearly the break. Break in the continuity is known as fracture. So this is called a Jefferson's fracture. And the main structure which is very, very important, which we should consider in these injuries, is injury or otherwise to this transverse ligament. Transverse ligament stretches transversely across, and if this is intact, then this is a stable injury and it's not fatal. But if this is injured, then this is an unstable injury, and because the most important centers are very near to this vertebra, and death may be instantaneous or very fatal outcome may be the result in these injuries. So you should know that this is the transverse ligament is the main structure which will tell you whether the patient will make it or not. Coming to another variety, another fracture, this is a Hangman's fracture. This is a traumatic spondylolisthesis of axis. This is fracture dislocation of the axis. This is the axis vertebra, and as I have already told you, this is the dents which makes it peculiar and easy for us to identify. Here what happens is there is a dislocation because of the fracture here. These posterior elements, there is a fracture, and this moves in front of the inferior vertebra. Once this goes like this, then the neural elements which are coming to spinal cord and all, they get snapped, and it will lead to fatal consequences. This is what happens in judicial hangings. So whenever somebody is sentenced for death by hanging, so this is the noose which comes beneath the neck, and there will be a hyperextension movement which will lead to fracture of the fracture dislocation of the axis, and which leads to instantaneous death. So this is otherwise known as, this is what happens in judicial hangings. See, this is a pictorial depiction, this is an X-ray, this is C2, same thing here, there is a fracture here, and which will lead to death. This is Hangman's fracture. There is one more term. I just want to make you aware that there are several terms associated with it, and all of you should be familiar with this. Clay shoveler. Clay shoveler means a fellow who shovels the clay from mines. It's a very hard job, and sometimes it may injure the spinous processes of the vertebra. Here you can clearly see this arrow depicts the clear gap between the spinous process. This is a fractured spinous process, and this is the attached spinous process. This is because of the sudden flexion. If something falls, heavy falls on the top of your shoulder, at the junction between neck and shoulder, suddenly it goes into flexion. Because a lot of muscles get attached to these things, that sudden contraction may snap and will lead to this fracture. This is something like akin to some olecranon fractures, wherein the triceps muscle sudden contractions will lead to fracture of the olecranon. Similar mechanism operates here, and the patient may come to you with severe pain, and movements are restricted here. Another fracture is known as a chance fracture. A chance fracture is because of the seat belts. Previously, seat belts used to be, there is only one loop which goes across your abdomen. But nowadays, we have one more loop which goes in between the shoulders. So, these seat belts, latest seat belts will prevent this chance fracture. But most of the times we see so many drivers take a chance not wearing the seat belts and driving. and driving at high breakneck speeds. If you take a chance, there is a chance that you will have a chance fracture. Because suddenly if there is a sudden deceleration, then your vehicle stops but your body won't. Then all the hell breaks loose. So this chance fracture was commonly seen in olden days with seat belts on. Here what happens, but the deceleration, there will be flexion first, then distraction. So flexion causes injury to the anterior structures. Maybe the anterior column is injured in flexion. In distraction, because of the muscle pull, there will be injury to the posterior structures, posterior column. So there will be injury to both the columns. And as you have already know that injury to more than one column is unstable and may lead to lot of complications. So chance fracture, never ever take any chance so that you will get chance fracture. This is undertaker, not your type of undertaker. I know that all of you are big fans of this WW and so many heroes are there for you. He is one of them. I have never seen any of those fights. But this undertaker, my undertaker is different. Here you find a body of the cervical vertebra, mostly C6 or C7, getting fractured. This is always a post-mortem fracture. So you should never ever get confused, because you should see all the bodies. Usually they do the X-ray before, and if you have a doubt, you should compare with the X-ray after the death. So you can compare both, and you know that because of the positioning, bad positioning, when they are doing the post-mortem, maybe they'll keep some blocks over the neck so that the head hangs down. So that may lead to fracture here. So this is known as a undertaker fracture. So as I keep telling you, along with your UG curriculum, now and then we will be telling you about for PG preparation as well. So this is a new term for you, undertaker's fracture. I don't know whether it's there in your standard textbooks or not, or then just consider that's the bonus for attending this class. So keep attending all the classes so that you will be paid bonus on a regular basis. So this is undertaker's fracture. Coming to various modalities of investigations in spinal injuries, especially cervical, then the routine X-rays, epilateral, but never ever try to turn the neck to get the X-ray. What to do while taking the X-rays, I will be telling you at the end of the class, but never ever try to do these movements of the neck to get a clear view. Okay, you may kill the patient by your movements. A cervical subluxation which is not seen may lead to cervical fracture dislocation by your movements, and you may have killed the patient even before you have taken the X-ray. So don't do that. How to manage an injured patient we will see later. So you need to know this X-ray open mouth view for C2, because unless you do that, you cannot see this odontoid process. Unless you see this, you may not know the true extent of the injury to the C2, because we have seen C2 fracture dislocations will lead to fatal complications. So you should be able to diagnose this. For that, you need to take open mouth view. These are all the teeth and mouth is open. So we have studied in our scriptures that God when He opened, the whole world is seen in His mouth. So even here, if the patient opens his mouth and we take an X-ray, we can see, if not the whole world, we can see the odontoid and C2 clearly. This is a scan where the fracture is clearly seen in the epi cuts. This is the another view. And all injured spine should be stabilized. This is, I'm talking generally about cervical spine, and this stabilization can be conservative or operative. And there are some measures in conservative method wherein you can stabilize the injured spine. This is the simplest of them. This is called a skin traction for cervical injuries. Or sometimes we have seen this type of traction being put for cervical spondylitis. Cervical spondylitis is as common as our aging process. Cervical spondylitis is nothing but price we pay for getting old. Okay, so aging is not a disease. So a patient, when they come to us, usually they tell, I have cervical spondylitis, as if they have that Padma Shri with them. So it's not a disease. You should tell them that it's not a disease. This is an aging process. Everybody can have it. If the symptoms are very severe, sometimes we may resort to this. This is known as cervical traction. This may lead to relief in pain because the pressure over the nerve roots may be relieved temporarily. The patient may get symptom-free time. So this is called a skin traction. Apart from that, you have a skeletal traction. Yeah, these are the apparatus. This is called a Crutchfield tongs, and this is called a Gordon's apparatus. Here, what we do, we make a hole in the skull. And for people like me, there won't be any problem because there is nothing inside. But you brainy guys, you should be a bit more careful. But we drill only the outer table of the skull, and we put this one inside. Once you put inside and tighten this, then it will hold on both the sides. And here you attach the weight. Okay, then there will be distraction and body, there will be traction, and body weight acts as counter traction because we keep the bed head up so that body of the patient head is up and feet are pointing down. That means it is a low level. So body weight acts as counter traction, and the weight which we add here acts as a traction. So this is Crutchfield tongs. This is another variety. This is called Gordon's. This is more safer because we can keep a count of how much depth we are going in. So if you say 1 millimeter, you can put it 1 millimeter here and tighten this. So it cannot penetrate. This may have a theoretical chance of penetrating into the brain. This looks a bit ghastly when we talk like this, but in the field they are very, very useful. Several cases we have treated just by putting this on, and patient daily, once you examine him, he gets better every day, and his neurological symptoms also improve very well. Okay, so this is cervical traction. This is a means of treating and stabilizing the spine. And another one is a halo traction. This is like a Hollywood movie, but believe me, these sort of apparatus are needed sometimes. Okay, so you need to connect these rods and fix them so that they are stable and they keep the bones separate so that the union will be fast and the neurological deficit is minimal. Now the patient can be like this. He can have normal walk, talk, everything he can do with the apparatus on. So these are all some of the things which can be done by modern medical science. Okay. Sometimes that is about conservative, but sometimes we may have to resort to what is known as open reduction and internal fixation for stabilization. Here, this is one of our cases wherein all of you can see there is a break in the posterior elements and there is a fracture dislocation. So there is a neurological deficit here, definitely, because this is going back and compromising the neural canal, and spinal cord is like a girl who doesn't suffer any insults. She doesn't want to, she wants to have everything on her way. So here, if there is any compromise here, it won't accept and it will lead to lot of complications. So this we have reduced by means of open reduction and kept it reduced by means of we put a plate, the anterior plate over the bodies of the vertebra, and this plate is kept in place by means of passing screws into the vertebra. Okay, this is how we stabilize the cervical spine. And this is another case wherein the fracture of the C2 fracture is fixed by means of transoral screw. So this transoral screw, and you can identify a C2 in all X-rays, lateral X-rays, by means of this spinous process, huge spinous process, above which the vertebra here has a very small process. So by this you can easily identify. So this is a transoral approach, and a screw is passed to keep the fragments together. So this is how we do this fixation. And sometimes the injury radiograph on which we draw those lines preoperatively, so that to quantify and to have a template. So what are the things which are injured and what needs to be done. So here you see the last one, say similar injury wherein the injury, the fracture, dislocation, and here there is a injury to the neurological spinal cord as well. So similarly the plate is fixed anteriorly. This is a plate and these are the screws, and this is a lateral view, and if you see from anterior, so this is how it looks. So this plate is sitting pretty on the anterior aspects of this cervical vertebrae. Okay. So what are the neurological deficits which can occur during injuries to the cervical spine? There may be a quadriparesis. Quadriparesis means not complete paralysis, muscle weakness. It could be in all four limbs. That is called quadriparesis. Quadriplegia, weakness of all four limbs, quadriplegia. Monoparesis or monoplegia, a single limb is involved. And plus or minus, this is a bonus. If the patient is unlucky, he will have this bowel and bladder involvement as well. If he is lucky, he may not have this. Okay, so these are some of the terms which all of you should be familiar with: paresis and plegia. So there is one more word. This is called a whiplash injury. All of you know what a whip is. A whiplash is a lashing from a whip. So this is usually happens. You need not hit the patient with a whip to have this injury. So it can be due to motor vehicle injuries. Here, sudden hyperextension followed by hyperflexion. So the patient will have bad of both worlds here. So usually happens in a motor vehicle road traffic accidents. So without seeing a speed breaker or vehicle in front, if you are texting and driving, suddenly you may have to stop. Your vehicle stops, you won't stop. Then there will be initial hyperextension followed by hyperflexion. This will lead to rupture of the interspinous ligaments posteriorly. So these spinous processes will have interspinous ligaments. Because of the injury here, the interspinous ligaments will get ruptured. This is a normal spine, cervical spine lateral view, and here a cervical spine after injury, whiplash injury. You can see the alignment is not regular, and this is different. This alignment is different and the spaces are also reduced. We don't go into those details, they are not important for you. You should know that whiplash can cause hyperextension, then hyperflexion, and lead to rupture of the interspinous ligament, which in turn leads to facetal joint involvement and fracture. So the inferior articular process and the superior they lock and they form the facetal joints. So they become unlocked. Then it will become, spine become unstable and there will be displacement. So this will lead to displacement and there may be rupture of the disc and the disc may protrude into the spinal canal as we have seen previously and may injure. So this whiplash can lead to severe neurological injuries. So this is a scanning of the whiplash victim. Here you can see injury to the bodies and it is going posteriorly and the spinal cord is getting pressed in this region. You can see it here. Okay, these are the posterior elements. This is spinous process and all. So if the injury is very severe, because this is cervical spine, it may lead to quadriplegia. All the four limbs are paralyzed. And X-ray may look normal. That is the greatest worry in case of this whiplash injuries. Because this is a momentary injury. The spine may get injured momentarily and the X-ray may look normal. Because the interspinous ligaments and facetal joints, the momentary injury which will lead to the spinal injury may not be apparent on the radiograph. So X-rays may be normal. But the patient is symptomatic and the signs are all there and patient is quadriplegia. Patient has quadriplegic and you don't see any bony, then you should go for MRI scans. These scans will show you soft tissue injury. So there may be soft tissue injury without apparent injury to the bones. That can occur and that can especially occur in whiplash injury. So just by looking at an X-ray, you can't make a diagnosis. So whenever the injuries is very severe and patient has all the findings like weakness and all and X-rays are normal, then you should subject him for the scan, which will show you the soft tissue injury and the hemorrhage which can occur in and around the injured part of the spine. So here, how do you treat it? So because of the injured cervical spine, you need to go for cervical traction. And the edema, immediately there will be some inflammatory response from the body. So this inflammatory response was designed to protect our body. But sometimes what happens if the inflammatory response goes haywire? That is what is happening in this COVID infection, pandemics. So here the cytokine storm is the main one which is killing most of the COVID patients. It's our own body's response. That's like a bodyguard is killing the person whom he is supposed to guard. If your response is not proper, then our own body is killing us. That means these cytokines, they are provided to protect us. But what is happening? This cytokine storm is killing us. Similar thing can happen here. There may be edema, and to reduce that, we need to use some steroids. Like in COVID infection, even in spinal injuries, we need to resort to methylprednisolone. Methylprednisolone will reduce the edema and reduce the damage to the cord. And this immobilization needs to be done either by conservative or by operative. We have seen procedures where a plate is fixed to immobilize the injured, fractured spine. So once you do that, then the spine becomes stable, then the soft tissues heal by themselves. And wait for neurological recovery. The spine which is injured has to get back to normalcy, which may take some time, maybe 3 months, 4 months, 6 months. So you need to periodically examine the patient and note down the recovery. That is about the cervical spine. We briefly touch upon injuries to the other areas like thoracolumbar. So here the main classification is stable, unstable. The stable injuries can be without paraplegia. If the spine is stable, then you won't get paraplegia. If it is unstable, because once the spine is a stable fracture, then the spinal cord which goes in the neural phenomena is not injured, because this is a spinal injury is a stable injury. But if it is not stable, there will be some protrusion into the spinal canal and injury to the spinal cord, then that will lead to neurological manifestations. That is mainly paraplegia. And some descriptive terms for the fracture. There may be a compression fracture. So if the vertebra is fractured like this is a compression fracture. There is a collapse of the vertebra because of the pressure from the top, compression pressure, or when there is degeneration or osteoporosis, then they just crumple. Then that's called a compression fracture. And if it is severe, they may become a wedge. See, the anterior measurement when compared with the posterior measurement is very much reduced. So this has become, instead of a square like this, it has become a wedge like this. So that's why it's called a wedge fracture. Usually occurs in the anterior aspect, and this is just like a collapse fracture. And sometimes it can be a burst fracture, the fracture line running in all directions, and several comminuted pieces may be seen here in a burst fracture. So this is called a burst fracture, a wedge fracture, and a compression fracture. Here the injury is spreading into the vertebra and makes it into several fragments. And mechanism of violence. It could be a flexion of the spine, like this. If somebody falls like this from the stairs, so there is a flexion of the spine here. So it's a flexion type of injury. Once there is a flexion type, some parts of the spine are injured. And in another type, hyperextension, if somebody falls like this, hyperextension, then the posterior elements will get some changes and the anterior. So depending upon the examination, once you examine the patient and once you see the radiographs, you may be able to ascertain whether it is a flexion injury or a hyperextension injury. Because it may not be always possible for you to get the proper history from the patient. Patient may not be conscious, or there may not be any witnesses who have seen the patient falling. So to know which type of injury it was, it is very important for you to know, because the management depends on that. So by examining the radiographs and the scans, you can come to a reasonable conclusion after examining the patient whether it can be a flexion injury or a hyperextension injury or a vertical compression landing on the head, diving in if you dive into an empty pool and if you land on your head, then it will lead to vertical compression. And a penetrating injury from the anterior side or from the posterior side may lead to a specific injury pattern or a distraction injury which can occur in hangings. So these are some of the, and there will be a flexion rotation injury. Apart from flexion, the spine is rotated. So this is much more dangerous than a simple flexion injury. So the damage is much more severe and the neurological manifestations are much more severe. So you should know the mechanism of violence to offer best treatment. So these are some of the scanning pictures looking at which we can know what type of injury it was. So there is a crumpling here. So this is a compression fracture. So the most probably the direction of the force is denoted by the arrow. And if you find a fracture like this, multiple fragments, this is called a burst. It just burst, okay, with several fragments. So this is compressed and this is burst. I think you can make see the difference between these two, a compression and a burst fracture. Then this is a flexion distraction. We'll come to that later. What is that? Then this will, if the injury is much more severe in this direction, then it will lead to fracture dislocation. Fracture, then dislocation. Once these posterior elements are injured and fractured, then the vertebra beneath lies stable. This goes back, and the spinal cord, which is going in the neural foramina, gets injured. Complete flexion, pure flexion violence. Here what happens is anterior wedge compression. You can see anteriorly, because the direction is like this. Once the injury is in this direction, then the person folds on himself. He leans forward. That means he flexes the spine. Once that happens, there will be a wedge compression fracture. If the posterior structures are intact, usually they are, then it is a stable fracture, which we have already seen. Only anterior column fractures, they are stable. Then they can be easily managed because there may not be any deficits. And sometimes you see this most often in osteoporotic patients. There will be wedge compression fractures, and injury may lead to wedge compression fracture at one level. But osteoporosis, if you take the normal X-ray in a say 70-80-year-old person, then you will see this multiple wedge fractures. See, that is because of the weakness in the spine, osteoporosis, which will lead to wedge compression fractures on their own. So we are very fortunate that there may not be any deficit in these injuries because the posterior structures are very much intact. Coming to flexion with translation. Translation means moving forward. This is a much more serious injury than a pure flexion injury. Here, there will be disruption of the entire spinous ligaments. So, interspinous ligaments being a posterior column, so there may be injury to the disc in the form of a rupture, and anterior fracture of the body is the first injury. Then it will lead to rupture of the disc, and if the injury is very severe, it will injure the posterior ligaments. So flexion with translation is much more serious injury than pure flexion. And flexion rotation, this is also serious than normal flexion. Here there will be fracture of the body initially, then dislocation of the facet, which will lead to rotation or dislocation of the spine. So once that happens, then there will be most likelihood of neurological manifestations. So these are some of the X-rays which show vertical compression, and this is the burst fracture which we have already seen. This denotes very clearly. Then coming to the extension violence, because once injury occurs, some injuries, deceleration or something, when vehicle stops, you don't stop, then you may go into hyperextension later. Then rupture of the anterior ligaments, because there is a bend on the posterior aspect, then pressure on the anterior ligaments, there will be rupture of the anterior ligaments, and the posterior complex may be intact. If that is there, then maybe a simple injury of the anterior ligaments. So it can be a stable injury. All this depends upon the severity of the violence. If the violence is very severe, then the damage is much more severe. So here, whenever the spine is injured, then we need to shift the patient without causing injury to the spine. So all of you know that there is something called a second injury. Second injury is one which we cause without knowing about the pattern of the injury, and the minimum injury is maximized by our attitude of how we shift the patient. So always you should use a spinal board to shift the spinally injured patient. So you should assume spinal injury, especially cervical spine injury, in a multiple injured patient. If the patient is lying down at the side of a road and he is injured, and if once you go there, you assume that patient has a neurological head injury and neurological deficit because of the cervical spine injury. So you need to transfer him to the hospital on a spinal board. How we do it? We see. Then rule out injury to the head and injury to the cervical spine in the hospital. Don't try to examine the patient by moving the neck here and there, leading to death of the patient because of the second accident. Don't ever do it. So you need to roll the patient onto the spinal board by means of this log roll method. This is how you do it. So this is a board and this is the patient is there. So you need to have at least 2 people to support the patient and to shift him onto the spinal board. It should be like how you roll a log in toto. It's not like somebody is first you put the neck, then you come this side and put the legs here. If you do that, then trunk will lie here, and then you put the trunk, then there will be awkward angle here, and it may lead to snapping of the cervical spine. And by the time you put the patient onto the board, he will go to mortuary rather than to the casualty. So never ever do that. You need to do this. This is called a log rolling, and you need to secure the patient onto the spinal board by means of these restrainers. So you need to restrain the head and the neck by this, and the abdomen and thorax, limbs like this. So patient is stable. So you can carry him wherever you want, any long distance, inside an ambulance also, by securing him like this. So this is a spinal board with the restrainers. All the emergency ambulances now you see on road 108 and all, they should have this. This is the minimum required to carry the patient, multiple injured patient. So anti-edema measures, as I have already seen, methylprednisolone. Of late, this has come into prominence again. This is a game changer now, even in our COVID infections. So it will prevent damage to the card. And management of the spinal injuries, X-rays we have seen, and this should be done on the spinal board, and most of the spinal boards are radiolucent, so you can do X-rays, and once you see and once you know that it is stable, then you should always put a cervical collar onto the board. When the patient lying on the board, you should put a cervical collar on. So unless you examine the patient and rule out a possibility of the cervical spine injury, patient should be having the cervical collar on along with the board. And a CT scan is a must. If you can't make a diagnosis and fracture is unstable, definitely you need to decompress the card, because the spinal canal is compromised. So you need to take out the structures, a disc or a bony fragment. That's how you decompress the card and fix it for stability. These are the broad general rules. So similar picture which you have seen. So coming to you have seen fixation of the cervical spine. This is a lumbar spine. You can see 2 screws going in to the body from the posterior aspect here. So here we go posteriorly and fix it by means of this rod which goes through the nut here through the screw, and this keeps it distracted. This keeps as you tighten the screw, then because as you tighten this nut which is attached to the screw, there will be distraction. Once there is a distraction, then the pressure over the nerve roots or the spinal cord is reduced. Once that happens, the neurological recovery is much more secure. So this is known as a Mars-Miami type of fixation. This is called Mars-Miami fixation, wherein you put a screw and put a special nut and pass this connecting rod through that, and you distract. After everything, you distract. So there will be that collapse, which is because of suppose this fracture is, this vertebra is fractured and there is collapse here. Then by passing a screw in the normal adjacent vertebra and attaching this, and by distracting you are taking out the pressure from here, and that compression also is reduced. That's how you decompress. This is decompression and fixation. And unstable chance fracture, these are the scan pictures. 3-level involvement, X-ray may be normal, but scan gives you the, and this is how you position the patient during spinal surgeries, especially lumbosacral. We go from the posterior aspect. So we keep the abdomen free for respirations and all. So all the organs are being protected by means of sponge cushion. These are meant to protect the important organs, pelvis and chest, and is protected here. And this is the operative pictures. So this is how, this is the nut which is attached to the screw. Screw is there inside the vertebra. This is inferior vertebra, this is the superior vertebra. This is the area where the vertebra is injured and there is a collapse. So once you pass the connecting rod and once you tighten this, then there will be distraction. The rod, you can see this is narrow when compared with this appears a bit long. So once you distract both of them, then there will be decompression and stability. So that collapse is being reduced by means of this Moss-Miami procedure. So this is how it looks post-operatively. So this is a lateral view. You can see the screws getting inside the vertebral body, and these are the connecting rods. And cord injury, initially there may be a spinal shock, then reflex activity, and then residual paralysis. So we want to reduce the extent of this paralysis. So we need to do whatever we can, okay, whether it be a conservative management or operative management. Our endeavor is to reduce this residual paralysis. So here, how do you know that the patient is coming out of the spinal shock? So there is a reflex called bulbocavernous reflex. This is a very, very important reflex, and all of you should know how to elicit and record and know whether it is still present or absent. So here in male, if the glans is stimulated, the anal sphincter contracts. So you need to do a PR, keep the finger there and stimulate the glans. Then if there is a contraction of the anal sphincter, that means return of this bulbocavernous reflex, which indicates that the spinal shock is over. Usually that is around 48 to 72 hours after the injury. But in women, we need to pass a Foley's catheter inside the bladder and inflate the balloon and tug on the balloon. Then you feel the contraction of the anal sphincter. That indicates that it is present. So this reflex involves S1, 2 and 3 nerve, sacral 1, 2 and 3. Coming to management of paraplegia, you get a patient who was injured in a road accident, has a spinal injury, fracture, dislocation. You do what all you need to. Then there is some residual amount of paraplegia. Then you need to take care of the general condition of the patient. Then psychological patient. These patients are psychologically very much down. Till yesterday, patient is moving, using all the limbs, and he is very, very mobile. And suddenly, for him to get onto the bed and unable to move his limbs, it's definitely a very big blow. And patient will definitely be down. And you need to have this psychological counseling as well. Unless you do this, identify and do this, patient may not get better. So you need to resort to this psychological care as well. Then the skin and the bladder, bowel and rehabilitation. As the patient is getting back his neurological function, then you need to rehabilitate. This plays a very, very important part in rehabilitation. It's not enough as a doctor for you to just do the surgery and just leave him. So all these things will fall into the care of a paraplegic patient. And most of you must have read about this automatic bladder and autonomous bladder. Automatic bladder is seen in case of upper motor neuron lesions, and lower motor neuron will have autonomous. Thank you very much, and I don't think after the class you are like this. You should be like this. Okay, so read, and if you have any doubts, definitely get in touch with me. It will be my pleasure to, if at all there are any doubts, I can always clear your doubts. Not only that, because it's very difficult nowadays to get advice, because the University of WhatsApp is giving doctorates and postdoctoral fellowships and so much of knowledge overflow, and we are not able to understand what is happening. So if you have any doubts regarding how to manage or how to proceed, if your near and dear ones, or if your neighbors, they think that you are a big doctor studying in a very big college like Medicity, so you must be knowing everything about COVID, and they may ask you, and then you can always tell them, just give me a minute, let me wash my hands, I'll come back to you. Then you can call me, and if you are any of our faculty here in the college, and you can get your doubts cleared, and don't unduly be worried. At the same time, don't be carefree. Take care of yourself, take care of your family. Sanitization and mask, physical distancing, all these things should be a way of life for you guys now, and you should be a health ambassador, and you should look after the health of yourself and your family as well. Thank you very much. Till next class, bye.